Wonderful. We have Nona here too. Wow. That's a treat. So, hello everybody. It's good to be back on our speaker series. This is the first talk in the series of this academic year. So, we set up this series to be, sort of an interactive, way for us to learn more about public health work that has been done locally, nationally, and globally. We have a stellar group of speakers coming. The first one coming today, and she'll be introduced by Angela in a minute. So the goal here is for us to have questions at the ending, and we have the logistics informed in a minute. But let's use this opportunity for us to reflect and learn about public health and how all things public health related are now happening in the globe right now. So with that being said, I welcome you all, and I will ask our dear colleague and friend Angela to kick this off.
Great, thank you, Rodrigo, and welcome everybody to our first installment of Public Health Speaker Series for this academic year. It's so great to see everybody here. Just a couple of logistics for those of you who are new to Public Health Speaker Series. We'll have our speaker talk for about 40 or 45 minutes, and then we'll open it up to questions and answers at the end. Of course, you can put your questions in the chat and feel free to put those in there as they come up for you as our speaker is talking. And in the end, we'll facilitate a question and answer period. And again, you can either do that in the chat, or we also highly encourage you to come off of mute and ask your question live as well. Before I introduce our speaker, I want to give a special thanks to the Center for Health Economics and Policy, and in particular, Tim McBride, who is one of our highly esteemed faculty colleagues. He's with us today, and he knows Nicole very well and connected us to her. So thank you, Tim, for making this happen for us. And with that, I would love to introduce our speaker today. Today, we are graciously hosting Nicole Comeaux. She has a JD and an MPH, and her talk title is Driving State Pandemic Response Through Medicaid Policy. She is the New Mexico State Medicaid Director and was appointed by the governor to serve in this role on January 7th, 2019. Prior to this role, she served as a senior advisor at the Centers for Medicare and Medicaid Services, where she served as the deputy director in the Center for Consumer Information and Insurance Oversight as well. Nicole has also served as the deputy executive director of the Kentucky Health Benefit Exchange Connect. She has a Juris Doctorate and Health Law Certificate from the St. Louis University School of Law, and a Master's of Public Health from our friends down the road at the School of Public Health at SLU as well. So I would like everyone to help me give a warm welcome to Nicole, and thank you, Nicole, for sharing your insights with us today.
Thank you all so much, I am very excited to be with you all today. It doesn't feel like all that long ago that I was sitting in your seats, but just about 11 years ago, actually, and remember these talks very well, and always ended up really appreciating hearing folks' career paths in particular. So that's where I'm going to start off with you all today. And let me get myself situated here, make sure I've got my notes up, and I'll go ahead and share my screen. Great. Okay, can you all see that cover slide? Yep, okay, good. All right, so I'm going to talk a little bit, like I said, about career path. And like I said, it was just mind-blowing today to think about what's happened in what feels like a very short time. I am a little chatty and run on, and so I'm going to do my best to get through kind of three major areas with you all today. Talk about how I got here from where you all sit today. Talk about the unbelievable role that Medicaid policy has played in responding to the COVID-19 pandemic, which I'll call the public health emergency, or PHE, going forward. and then very briefly talk about the intersection of that pandemic response in light of our state's decision to expand Medicaid. As I imagine, it is a frequent topic for you all, given the recent activity in Missouri around Medicaid expansion. So I could not have a conversation about the pandemic and my career without introducing you all to my coworkers for the past 2 years, and acknowledging for any of you who are trying to balance work and school and being a caretaker for either your children or family members or friends, that it has been hard and a crazy 2 years. And if no one has said it to you yet, you're not alone. And for all of you trying to make your way through that, I am more than happy to commiserate, offer advice, etc. And Tim and folks know how to get a hold of me, and always happy to talk to folks about kind of juggling the two of those things. So I'll leave that there. And like I said, wasn't that long ago that I was listening to folks give these talks thinking, how on earth am I ever going to get to those roles? It seemed so challenging to figure out how to get to the place that I heard folks speaking about that sounded so incredible, but it wasn't kind of those traditional paths like doctors or lawyers practicing in the traditional sense, where things are kind of laid out for you, and it's this stepwise way to get there. And in public health, it always seemed kind of daunting to me. Like, I saw these incredible people doing incredible things that I wanted to do, but I couldn't understand how they ever got there. So I wanted to share with you all my experience, and as cliche as it might sound, just let you know that relationships, hard work, and saying yes to opportunities, even when you feel like you might not be ready, and doing what you love, somehow get you there. I should say first, I'm a first-generation college graduate, only college graduate in my family, and I was a good student, but frankly, not the best student, not the top of the class, Tim might tell you, but I love health policy. And I think that really drove me and helped me kind of continue on what has been a very, very fortunate path. So I was standing in line in graduation in 2010, right after the Affordable Care Act had passed that March. It was July when we were finishing up. And all I wanted to do was work for the Centers for Medicare and Medicaid Services and help with the implementation of the Affordable Care Act. Me and every other policy wonk in the country. And I had submitted dozens and dozens of applications to the black hole of USA Jobs, which I hear has improved, so good news there. But I was graduating unemployed. And I actually remember the person standing in line trying to congratulate all of us and pump us up as we were going out to graduation, and someone behind me mumbling, somebody didn't give her the memo that none of us have jobs, graduating in the time of the recession. So Tim had graciously agreed to meet with myself and 2 other students as we whined to him about our struggle. And he had just transitioned actually from SLU to WashU and still made time for us. And I'm eternally grateful to him for all that he did for all of us, and me in particular. And he had agreed to pass my resume to a colleague at the Health Resources and Services Administration, which is another division of the Health and Human Services Department at the federal level. I hadn't applied there because my focus had been the exchanges, and I thought that I had to be at CMS to try and start to work on this implementation. But as I sat in my seat at my law school graduation, I kid you not, the director emailed me during graduation and said that they wanted me to come sit as the lead on their federal regulatory team, which meant that I got to work on all the regulations that were a result of the ACA and make sure that rural providers weren't disproportionately impacted or neglected. I was thrilled to accept the position, and being on that team ended up meaning that I got to work with a cross-functional team from all of the federal agencies, including CMS, before regulations went to publication in the Code of Federal Regulation. So not long after I was there, I was asked by the Center for Consumer and Information and Insurance Oversight, the exact office where I'd hoped to work, if I'd be willing to help them review the 1113 grant applications for, just switch my numbers there, 1311 grant applications for the state seeking to establish exchanges. And I said yes. And Shortly after getting to know that team and working on those funding applications, I was offered a transfer to oversee the implementation of the exchanges in New Mexico, California, and Kentucky. It was such an incredible time, truly, and so much fun to be part of a brilliant, passionate team working on the implementation of this kind of really once in a generation policy. So I introduced you to my babies, but I neglected to introduce my husband, which he would probably claim as commonplace, but he's also an attorney and had joined the JAG Corps when we left school. So we'd been long distance, him kind of all over the country, and I stayed in DC as a result, but somehow worlds aligned. And as he was getting transferred to a base in Tennessee, I was offered the deputy director position by the team I'd been working with in Kentucky to go help run their incredibly successful and just amazing exchange down there. I was honored and excited and frankly, really scared. I think I was just turning 31 at the time and still felt like I had a lot of learning to do, but said yes. And it was the best team and job I could have ever asked for at the time. We continued the full integration of the Medicaid and exchange and other benefit programs there, which really no other state had successfully done at the time. Other benefit programs being SNAP and TANF and LIHEAP. 2 years later, a Republican governor won the race there and set out to dismantle everything we had built. Most of the political employees were fired, and I was sure I was next on the list. But I reached out to some CMS colleagues and had kind of fallen in love with Medicaid policy while working on that really integrated project at the time in Kentucky. I was able to work with some folks and again, really fortunate to maneuver back into CMS, but this time on the Medicaid side instead of the commercial side. Again, by chance, I was assigned New Mexico and as well as several other states, but ended up working with them on the implementation of a couple of efforts that they had underway here. I really got to know Medicaid policy at that time, and again, just knew that that was where I would end up wanting to spend probably the majority of my career. Medicaid is a never-ending challenge, and the policy is so complex and so many unique problems to solve that you will never be bored. So my mentor and boss at the time was a political appointee, and after I'd been there for not long, Donald J. Trump was elected, and my boss was moved into another place, and I was asked to start working on the work requirements applications for states, and not a direction that I had ever intended to go. And my love of Medicaid policy did not lead me to want to continue that work. But meanwhile, in New Mexico, Michelle Lujan Grisham, who I'd been working with since 2013 on the New Mexico exchange implementation, she was working as a secretary at the time, and then went on to be a federal legislator and ended up still working to help push the implementation here. Had been elected governor. And on Thanksgiving Day in 2018, I got a call from her and her team to come down to New Mexico and run their Medicaid program. By January 1st of 2019, I was 8 weeks pregnant at the time with a 15-month-old as well, and a husband stationed in Virginia. It's not very easy to move the military for any of you who are familiar or not. So not sure how I was going to make it all happen. And it's been a wild ride ever since. But being a Medicaid director, really despite all my fortune and all my other roles to date, I think is most likely going to be the hardest and the most incredible job I have ever had and probably will ever have. There are only 50 of us, obviously 51 in the country at any given time. So it's like a fraternity of sorts, and one that I feel so privileged to be a part of. So all that said, it is a bizarre winding road, not a stepwise path that folks outline for you in the way some other careers happen to work. But do what you love, build those relationships, work hard and say yes, and somehow you find amazing opportunities. I've learned more in the past 3 years than in any other job, and I've worked harder than I ever have. More all-nighters in this job than I ever did in law school or my master's program, I'll tell you that. And that said, I am so proud of our team and what we've accomplished. So let's jump into the work here and talk to you about what we've been doing. So, oops, sorry, clicked back. The babies are just too cute. Can't skip past. All right, so I wanted to talk about Medicaid in the context of the pandemic, and in order to do that, I needed to give you some context about the program here in New Mexico. So, check my time. So New Mexico actually has the highest population percentage covered by Medicaid of any state in the country. And as you'll see later, that's due to our poverty level and also due to the fact that we did expand Medicaid here. And what comes with that is really a huge responsibility. We are the largest payer in the state, and a state with a really fragile healthcare infrastructure. There's only one level 1 trauma center here in New Mexico. The vast majority of our healthcare is delivered in rural settings across the state. And being the majority payer means that there's really nowhere to shift costs when you're a provider, when Medicaid is the largest payer. So we have a responsibility to make sure that not only are we helping really provide adequate payments to those providers, but that we're also helping try to maintain and grow that healthcare infrastructure so that it's available not only to Medicaid members, but available to everybody else in the state as well. There is a very strong guiding principle here, given the poverty level of folks in the state, that we will take advantage of and leverage every federal dollar that is available to us. And of course, while maintaining strict compliance with the law, there's a story behind that, but always important for us here in New Mexico. And what that means for us as a state is that every federal dollar that we pull down is one general fund dollar from our state revenue that can be put somewhere else where it's needed. So that is the way that we operate our program here. The population in New Mexico is about 1.2 million people, a little smaller than you all. And when the pandemic started, we had about 834,000 Medicaid enrollees. Now we are projecting by December that we'll have 957,600 enrollees. And that growth in large part due to the pandemic, but also due to the maintenance of effort requirements associated with some extra federal funding that Medicaid agencies were allotted to help weather this pandemic. That means that by December, 46% of all New Mexicans will be on Medicaid. And again, just highlighting the importance of our responsibility in helping ensure that we have an adequate healthcare infrastructure that's paid appropriately. 82% of our enrollees are in managed care. We have a fee-for-service component of our program still here. The vast majority of those enrollees are Native American. There is some historical reasons why, and a lack of trust with managed care organizations that mean that the majority of those enrollees would like to stay in the fee-for-service side of our program. I think the most shocking numbers for our program here are that now upwards of 58% of all children in the state are covered by Medicaid, and now about 72%, the slide is a little bit dated, 72% of all births in New Mexico are covered by Medicaid. So gives us a lot of levers as well to try to reach that population, and that has enabled us to respond to the public health emergency as well. We'll talk a little bit more. So we are like most states. This is what the case count of COVID-19 has looked like here in New Mexico. We're further west, and so but not on any of the coasts, obviously. So the pandemic got to us a little bit later than it got to others. So you can see that our spikes really begin a little bit later, late March, April of 2020. And then again, the Delta variant spike there at the end of the slide. I give you that timeline because we're going to talk about funding here in a minute. So when the pandemic began, I'd been talking to our secretary here and our economists, and we knew at the outset, which was confirmed early on and has continued to be the case, we knew that unfortunately this pandemic was going to have a disproportionate impact on our enrollees, on folks at the lower end of the federal poverty level. This graph on the right is grouped by census tracts and the percent of the census tract that is below 100% of the federal poverty level. So calling this out because in New Mexico, COVID-19 positive individuals in census tracts with greater than 40% of their population below 100% FPL are being hospitalized at 2.5 times the rate of the wealthiest New Mexicans. They are admitted to the ICU at 1.5 times a greater rate, and they're 2.6 times more likely to die from COVID than are the wealthiest populations in census tracts. So we knew we had a huge job to do to respond and to try to minimize what was the likely very significant impact of this pandemic here in New Mexico. Like I said, very fragile healthcare infrastructure. There's only 3 large hospitals and only 1 level 1 trauma center. They're all located in the center of the state. So when you hear states talking about on the news, their beds are full, there's nowhere to transfer people, that has often been the case here, and often always on the verge of rationing care. So how do we respond? So there were a number of different ways that we knew we'd be able to respond given our current authority, but we'll say that our federal partners played an incredible role in really quickly getting out to states a number of federal policy levers that we were able to pull to respond. So on the left-hand side, and these are linked and I will share my slides, you can see the major state and federal policy levers. Declarations of federal emergencies allow for a number of things, but particularly 1135 waivers, which gave us huge flexibility in how we allowed for alternative care sites, for example. So we could set up med tents to deal with the massive overflow from our hospitals. Disaster relief state plan amendments. So normally state plan amendments, Medicaid operates under state plans. You can amend them. Takes a long time and requires public notice normally. CMS quickly pivoted to allow us to use the disaster flexibility so that we could quickly make changes that we needed. And we'll talk a little bit about what those are in a second. Section 1115 demonstration waivers, again, normally take a long time to implement. We operate within a state plan framework, but those demonstration waivers allow Medicaid programs to say, hey, CMS, we want to do something a little bit outside of the norm, experiment, if you will, with our program administration. And we'll evaluate that for you to show you if it's effective or not. And states do that in a lot of ways that are longer term normally, but allowed some flexibility that many of us have taken advantage of. And then finally, 1915C, home and community-based services waivers. There's a section of them that have emergency clauses in Appendix K of that waiver authority that allowed us to do a lot of things for that home and community-based services population, which was critical at this time because, as many of you I'm sure heard, folks in congregate care settings like nursing facilities were having huge impacts and huge case rates and death rates, and encouraging and allowing flexibility for payment for services delivered in the community or in the home allowed us to keep many, many folks out of those congregate care settings and allowed us to do so quickly when we started seeing that happen in other parts of the country before we had really begun to experience the full effects of the pandemic here. So sorry, on the right is our response. We were in the first, I think, 7 states to submit a huge package of waivers. We have 2 approved 1135s that have probably 35 different waiver proposals within them. 4 approved 1915Cs, 1 that is still pending, and a number of state plan amendments as well. So those are kind of waiver authorities that we took advantage of. And those came out of that first federal policy lever that was listed there, which is the declaration of the public health emergency. I'm sure you all have talked about this quite a bit, but Secretary Azar first declared the public health emergency under one of the 3 federal emergency authorities in January, and then the president declared under a different authority in March. Those two declarations triggered the ability for us to do a lot of things, in particular, apply for those 1135 waivers, and also for CMS to issue blanket 1135 waivers that applied to Medicare, and then any state that had a Medicaid program as well. And I'll give you some examples in a second to give it some more context. But that public health emergency authority is active for a 90-day period, and then it terminates, or it can be terminated prior to that 90-day window. So what that has meant for states, and as you'll see as we get further along here in some of the legislation that was passed, what that's meant for states is that we are hanging in the balance every 90 days, wondering if we're going to continue to be able to exercise the flexibilities that we are under the law, and also wondering if our budgets are going to continue to be supported by additional federal revenue that came out of FCRA, the Families First Coronavirus Response Act, and is tied to the Public Health Emergency Declaration. So that has made operating programs in the states incredibly challenging. So when the Biden administration came in, they sent a letter to our governors allowing state Medicaid agencies, well, telling state Medicaid agencies that the PHE would likely remain in place until the end of calendar year 21. That will likely change now, given where we all are, but we don't have any official notice of that yet. And that they would give us at least 60 days notice prior to termination, which gave us some peace of mind and ability to operate our programs. So what did we do with all of that? Kind of two big things. So first, we wanted to make sure that we were protecting and extending access to coverage and care for all New Mexicans in light of a public health emergency. Second, we wanted to ease burden for our providers. We wanted to make it as easy as possible for them to do their jobs. So I'm not going to go through all of these. There's a lot of work that many states have all kind of undergone in the same way. Sorry for the text heavy slide, but I think some of these things are pretty incredible that Medicaid agencies were able to do. One of our 1115 authorities, we were able to allow coverage for uninsured New Mexicans regardless of their federal poverty level, and we were able to pay for their testing and treatment. And we also expanded the definition of emergency Medicaid services for aliens, which we have now changed to non-citizens, but that is how it's still listed in our statute until about 2 weeks. And we expanded that coverage to include testing as well. Treatment was taken care of through another federal authority, but those are pretty incredible things to establish a category of eligibility essentially overnight, thanks to those waivers. We also relaxed restrictions on early prescription refills so that folks could stay home and didn't have to keep going out and getting exposed over and over again at the pharmacy. A number of things like that to make sure that folks had access. We increased telehealth and phone visit options so that people didn't have to go into doctors' offices and could still get the healthcare that they needed. And we also, like all other states, because we all wanted to take advantage of that extra federal revenue, we also stopped disenrolling anyone who was a Medicaid enrollee, but was no longer eligible after March 18th. So anybody who had been on the program at that time or who has come on since March 18th has stayed on the rolls and will continue to stay on the rolls until the end of the Public Health Emergency Declaration. Again, all policy driven through these emergency levers that were made available to us in the context of that declaration. So I talked about the members on the last slide, talking about the providers. Some of the things that we had to do in particular here, we have a large Native American population, again, 72% of them, 72% of the Native Americans in New Mexico are on Medicaid. We had really significant outbreaks of COVID on some of those tribal lands and no facilities nearby to help take care of those individuals beyond the IHS facilities and needed higher levels of acuity care. And so We were able to, again, submit in our waiver authority to establish alternative care sites. Normally, you have to have an enrolled Medicaid provider, a big process to be able to actually spend state and federal dollars to reimburse for the care that's being provided. Those waivers overnight allowed us to set up these facilities in some of those hardest hit areas and be able to use Medicaid dollars, both state and federal, to pay for the care that was delivered there. Number of other things that we did under those waivers as well, but I'll move forward unless there's questions about them at the end, just for sake of time. Couple of other things, again, under existing authority, a lot of which we took advantage of, was considering that our managed care organizations, managed care is a capitated arrangement, as I'm sure many of you all are learning or know about already. And that means that we continue to pay a per member per month fee to our managed care organizations for all of these enrollees. And you saw our enrollment growth just skyrocketed. Our governor, at the beginning of the PHE, when you saw that most significant spike on our graph, did clamp down, and we suspended elective procedures. We closed down our state quite a bit. And that meant that there was a significant underutilization of services. So we were paying the managed care organizations to provide care to our people, but those people weren't getting care. So we wanted to find a way to not allow a windfall to flow to the managed care companies, and instead directed them through some existing authority to pay for rate increases to our providers where we knew they would still be delivering services. So like I said, we suspended elective procedures for our hospitals. So that revenue source for them gone for a period of time, but we knew that they'd be having much higher levels of folks in their ICU beds and folks in their inpatient beds due to COVID. So we ratcheted up their rates and what we pay them for the delivery of those services. And instead of changing the amount that we pay the MCOs to compensate them for that, we asked them to just absorb those costs. Again, all done through some state plan authority and preprint authority with CMS, but allowed us to help our providers weather a really challenging time for them from a revenue perspective. Number of other things. Now we are in heavy vaccination phase work, lots of pushing MCOs to drive vaccine campaigns. We have a rewards program here in our Medicaid program, similar to probably stuff that you all have on your credit cards, where if you engage in a healthy behavior is the way that it works here. For example, going to get your kid their well child check or going to get your vaccine, you get reward points that are equivalent to dollars that they can spend in a catalog. We filled up the catalog with things at the beginning of the pandemic that nobody could find. Somehow our vendor had access to toilet paper and hand sanitizer and thermometers and masks, things that people needed. So we filled the catalog with that and helped drive people at the time to go still get the care that they needed, get tested, etc. Now on the vaccine side, doing some other things in the catalog, but it was actually a pretty amazing response, and again just helped us kind of drive some healthy behavior around kids in particular when we saw utilization dipping. Okay. So those are some of the policy levers between the states and between our colleagues on the administrative executive side at the federal level. But what really helped make all of that happen, or really was responsible for making a lot of that happen, was the action that Congress took as well. So this is the list of the COVID-19 related pandemic legislation, the most important of which the most important, I think, one to Medicaid is really the Families First Coronavirus Response Act, the act that triggered an additional 6.2% federal match for states who agreed to that maintenance of effort requirement I mentioned previously. That has helped all of us weather this pandemic when state budgets crashed, and we all still needed to make sure that folks were getting the care that they needed. So what has that meant for us that when that passed, and we certainly agreed to leverage that 6.2% match. I'll talk about match in a second. Prior to the beginning of the pandemic, our program grew by 0.1% per month. And we used to disenroll about 1% of the population per month for a number of reasons. They're no longer eligible, they failed to renew their application, and provide documentation that was necessary to maintain their eligibility status. Since the pandemic began, our growth has exceeded this. Actually, again, I should have updated the slide. But at its highest, I believe, was about 1.9% per month. And we haven't disenrolled a single individual unless they passed away, moved out of the state, voluntarily disenrolled, or we moved them between categories, but didn't disenroll them. So want to talk about the financial impact of that. I talked about match. I'm sure you all are already covering this, but just to restate for the context of this presentation, the federal medical assistance percentage is the portion of Medicaid budgets that is financed by our federal partners. It's a shared program. The states put up their share, and the feds match with different rates for every state, depending on the poverty level of your state. So you can see here that New Mexico has one of the lowest per capita personal incomes by state. And actually, I meant to put the other map here, but which shows that we have actually the highest poverty level. I think we were just surpassed by one other state, but we're usually number 1 or number 2. And the way that the match rate works is designed so that the federal government pays the larger portion of Medicaid costs in states with those lower per capita incomes relative to the national average. For us, that means that our match rate normally outside of the pandemic is about 79%, between 75 and 79%, depending on our enrollment and programs and changes that we make. And so the reason that matters for us and for every state is that for every $1 of state general fund that we invest in the Medicaid program, the federal government gives us $3.65. During the pandemic, with that additional 6.2% that came out of FCRA that I mentioned, our match rate increased significantly. And for every dollar that we invest, the federal government is providing us with $4.76. That is a return on investment rarely seen. And so one that has helped us gain kind of significant partnership with our legislature in pursuing all kind of opportunities with the federal government as we kind of weather this pandemic. You can see Missouri on there. I think you all are in the 68 to 74% bucket there, it looks like. So a little bit lower poverty level, but still a significant return on investment every time you take advantage of these opportunities. This just shows you there's a number of different match rates by group. Certainly the other adult group, which is what we call it here. I think you guys are calling it something else, but it's our expansion population. Tim, you guys call it the adults. I looked at your slides, but adult expansion population, I think. So that group is matched at 90-10 and certainly drives up our match rate overall. But you can see how the others have impacted it and how the 6.2% has impacted our coverage in the last 2 years. This is just more information on that match rate and how long those will last. But I say all of that to really kind of lead into a quick couple notes, because I'm going to get to my 15-minute mark here about the expansion. So what this graph shows you is what that federal investment has looked like, especially during the pandemic for us. So our general fund need is that green bar on the bottom, the amount of money that we've needed to operate our program during the pandemic. Hasn't really grown, but the money that we've needed to operate our program in line with that red line on the top, our enrollment, has grown up to that larger gray bar that you see on the top there. But all of the gray has been filled by federal revenue that has flowed into the state to help us address all of this. We've been able to increase rates where we didn't ask the MCOs to take it on. We've been able to provide coverage for these folks. We ensured that everybody could get testing and treatment even before the federal government made changes to allow us to do so. And then we were again able to shift that cost to the federal government when those authorities became available. But I think it's just pretty incredible to see kind of the impact and the support that has been available to states throughout this and has really allowed us to operate. Without the additional 6.2%, and in a state where our entire revenue is really driven by oil and gas, our secretary makes us have the app of what the cost of a barrel of gas is on our phone every day. And Tim's laughing. Prior to the pandemic, a barrel of oil was about $50, $54. And when the pandemic really kind of hit its peak there early on, it dropped below $1 for the first time, I think, in a long time. And that meant that we had almost no revenue to operate our program. And we would have had to cut provider rates, cutting them off at the knees, basically when they most needed to be providing care to people across the state in light of the public health emergency. So just incredible policy levers and really fascinating things to be a part of operationalizing as we've moved through the past 2 years. I'll wrap up here quick. So this was to show you all kind of the volatility that states have been experiencing in their Medicaid programs. That line on the bottom, really need to make these different colors, sorry. The line on the bottom is what our normal Medicaid projection would have looked like. Each of the lines above are when we thought is the growth we actually experienced since March of 2020. And each of the lines shows kind of what we had expected to happen each time we thought the public health emergency declaration was going to come to an end. So now you can see we're at this top thick dark green line, and there was an anticipation that the public health emergency would end in December, but now we're expecting that to continue on further, and a lot of repercussions for that as well. Medicaid expansion, just really quick, we opted to expand. The enrollment in the program grew by 66% in a 3-year period and leveled off. And the uninsured rate in New Mexico fell from 18.6% to 9.2%, a drop of more than 50%, which was about 10% above what the national average was at that time. What that meant, not only for our people, was getting them access to care and services at the right time and the right setting when they needed it. And what that meant for our providers was an incredible decline in uncompensated care. Our safety net care pool hospitals submitted applications for $122 million in uncompensated care in calendar year 15, and that was a 30% drop from just the 1 year prior. Our hospital cost reports showed a 3.6% reduction in uncompensated care, and hospitals in the aggregate saw the uncompensated care amount drop to 7%. You can see on the right that it also impacted our primary care providers. Our FQHC payer mix shifted significantly from uninsured to Medicaid, and allowed them a significant increase in revenue, which allowed them to allow for capital investments, et cetera, better care of their patients, hiring staff, really allowing for better healthcare delivery in the state. This graph's a little bit hard to look at, but the top here is our expansion population. And so I talked about that crazy curve and the growth that we've seen during the pandemic, and really we've never seen anything like that previously, except for our implementation of the expansion, which you can see starting back at the beginning of this graph back there in 14. A little bit of a larger bump that then kind of levels off and stayed level for a long time until the PHE began there. The blue is our traditional Medicaid population, and then the light green on the bottom is our kiddos. And I want to just lastly say what that really meant for us is a full continuum of coverage in New Mexico. Pretty much no matter your circumstances between Medicaid, the exchange, and our high-risk pool is still in existence for a very small population. Between all of those coverage sources, we really have a full continuum that takes care of the population with such a significant poverty level. So excited for you all, and I will stop for questions and discussion.
Great, thank you so much, Nicole. I don't see any questions in the chat, but students and guests, please feel free to put your questions in the chat or raise your hand. And I see Tim and Ethan, so I'm gonna actually start off with Tim, if you don't mind starting us off with your question or comment.
Thanks, Nicole, and it's a little bit of feedback here. Can you hear me okay? Thanks, Nicole, for being here, and so proud of your career. But I want to say it's mostly almost entirely by your hard work. You're just one of the stars in the country. I want to ask about New Mexico and relative to Missouri. I know those really very different states in many ways, but you've been here, you know what we're like. And you expanded pretty much at the start, but lessons learned as we're about ready to launch an expansion here, and very different political environments, of course. But so I've been to New Mexico. My aunt and uncle used to live there. So as you mentioned, you're a pretty rural state with a lot of Native Americans. As I understand, Albuquerque is where most of the healthcare services are, and you have a high poverty rate, higher than ours, but a lot of rural areas. So there's a lot of significant challenges around providers. So what lessons can you say we should be worried about first? Because we're expanding literally right now. So what should we be worried about first as we expand Medicaid, and what should be in our first bucket list of 1, 2, 3?
Thanks, Tim. So I looked at your slides, and I had started a slide of considerations and things to work on, but you guys are tackling them. So you've got a good team doing the work that I think really needs to happen. I think in Kentucky, I went through the expansion with them. I wasn't, and they expanded right at the beginning as well. Fairly rural state, maybe closer in population size to you. What's Missouri's population?
We're 5 million people with about 1 million on Medicaid.
Okay. Kentucky's like 3.4 million, and rural challenges with healthcare delivery, certainly, and challenges implementing their expansion, but they did. And some of the things that were most critical there, which I see you all, it seems like, are already working on, was contracting for a provider capacity study, looking at the demographics and the socioeconomic status and the healthcare needs of the population that was going to come on, and figuring out how to help ratchet up, if you will, payment in those provider areas that are likely to kind of take the first wave of higher utilization. So we did that provider capacity study, saw where there were shortages, tried to help either provide additional rate increases, or also help to try to target them with additional flexibilities and outreach. We opened up some licensure requirements and reciprocity to encourage folks to come across the border to come practice there if they wanted. Increased telehealth flexibility to make sure that we allowed for delivery in rural areas where there may not be as much access, but certainly likely to be much more significant need, as our expansion in both those states, and I'm guessing in yours, was higher in those rural areas by percentage wise anyways. And so I think that provider capacity study was critical, figuring out how you could help support providers, and taking on that additional volume was also something that was really critical. I will say one of the concerns that both states had at the time was that it was going to have this huge impact on their budget despite the match rate. And what most Medicaid programs end up doing is supplementing the cost of covering or the coverage of the cost of care through other mechanisms like directed payments, and covering uncompensated care through those directed payments as well. And with the decrease in the uncompensated care, what ended up balancing out in both states was that really we ended up having not this huge negative impact to our budgets. It all kind of leveled out, and we had a healthier population accessing care as they should in the places that they should as a result. So I think you guys are already kind of tackling it. And I think you saw our curve, and I think it tracks with what you're seeing from other states as well, like when those enrollment peaks will come. So we'll leave it there, but you guys seem like you've got a great amount of research going already.
Great. Thanks so much, Nicole. And we have a few minutes left, and I'll go to Ethan, and then we had a couple of questions in the chat if we can get to those. And if we have time, Reagan, I'll call on you after that, but please, Ethan, your question.
Sure. So you talked quite a bit about MCOs today. Sorry, my dog's squeaking a toy in the background. And I would love to know, like, with your role as Medicaid director, how do you motivate them to do things like run a vaccination campaign or build, better relationships with the Native communities, like you were saying, because their business model is to just not spend as much money as you give them. So how do you motivate them to spend money on things that they might not want to do?
Yeah. So again, pretty incredible policy levers, and they are for-profit entities. So money is a motivational tool. But what I have been really happy to see during the pandemic is that all three of our managed care organizations here, we have two national carriers, Blue Cross Blue Shield and Centene, which operates as Western Sky here, and then Presbyterian, which is just a health system here in New Mexico. But all three of them have really stepped up to the plate and been excellent community partners. They've done things that they don't have to do outside the bounds of the contract that I've asked them to do. But I will say when we want them to do something that they're unlikely to do, we have some tools to amend the contract. And CMS, again, usually approves those contract amendments. And during the pandemic, it takes a long time. And during the pandemic, our federal partners have quickly reviewed those and really allowed us to be nimble in requiring the MCOs to do things that we want them to do. Additionally, there's things like performance measures we hold them to, HEDIS measures that we hold them to and attach dollar values to. So in New Mexico, a pretty stringent Medicaid program, we actually, the total dollars that they are able or have at risk on the penalty side actually exceeds the dollars that they could even make on the profit side. So we really try hard to hold them accountable, utilize performance measures that have dollars attached to them. On the vaccine campaign, they do, we don't have any downside risk with them. We only share on the upside. So if they have losses, we don't have to help cover those losses. If they have profit, capped at 3%, and we share everything with them above that at 50%. So they really don't want to lose money either, and they know that it's in their best interest to get the population vaccinated here. So they've been great partners in doing some really creative homebound campaigns and things like that. Our ambulance companies have partnered with us to get folks at home who couldn't get in to get vaccinated. And now the school-based health centers are partnering with us to get kiddos vaccinated, and also their parents just trying to meet people where they are. Still not great numbers on the Medicaid side compared to the state overall. They're good, but they should be better. So that's the case across the country from what we are aware of at this time. So that's really the tools we use. Good question.
Thank you so much. And we just have a couple minutes left. And Nicole, I don't know if you can address either one of these in just a couple of minutes.
Yeah,
but
I'll go faster.
the two questions, oh no, and that wasn't what I intended at all.
Oh, you're fine, you're fine.
But the two questions in the chat is one is the 6.2 match rate provided through FCRA, is that going to remain after the pandemic? And if not, how will that change things in the state? And then also, if you have time to speak to how little behavioral health care is covered under Medicaid, and if and how that's changed during the pandemic.
Yeah, really good questions. So the 6.2% is tied to the public health emergency declaration. And like I said at the beginning, the Medicaid directors are kind of a fraternity, and we are good friends with our sister fraternity, brother fraternity over there at the Governor's Association. And so all of us have been screaming pretty loudly that this cliff that will happen at the end of the public health emergency, where the federal revenue drops, but we still have now new CMS guidance, 12 months to roll off all of the individuals from the maintenance of effort. And I think you saw in my graph, it's not going to return all the way down to what our state has budgeted for operating the Medicaid program. Economic conditions in the country haven't recovered to that extent yet. So that cliff effect means that states have a huge population to cover with an overnight ending of our federal revenue source. So all of that has to then be made up by state funds. So that cliff and the impact on state budgets and Medicaid programs is terrifying, and something that all of us are watching very closely and lobbying our partners in Congress to try to help us with some sort of sliding scale, step down, maybe associated with economic recovery. Joblessness numbers would be more helpful, because then we could know that for sure Medicaid programs have kind of recovered and are back to what states are likely anticipating paying for them in their budgets and their base budgets. None of us have, of course, increased our base budget to cover this population because the federal revenue has been compensating for it for 2 years. So it makes a big problem at the end. Behavioral health care, such an important question, and has become even more spotlighted during the public health emergency. In New Mexico, we have integrated behavioral health into our managed care program. That is not the case in most states, but has allowed us, again, a lot of levers to utilize the MCOs and care coordination and try to work through ensuring that referrals actually happen. Our behavioral health network here was decimated through a big scandal in 2013, and is just now being rebuilt. We've seen a huge increase in need for care. Telehealth has been life-saving, truly, for folks who've needed behavioral health during the pandemic, and it's allowed us to redistribute care across the state in a way that we weren't able to before, particularly with the limitations on platforms like these and the HIPAA rules around them. So we are really hoping to continue those authorities, those flexibilities, after the end of the declaration to continue to serve that population. I think I saw one more. I can hang over. I think I saw one more.
I think as a comment for your giving you thanks. Oh. And I do want to thank you for being here and thank our audience for being here too. And Nicole, you have been very busy and we really appreciate the work that you're doing. And we really, really appreciate you taking the time to be here today and letting us know about this really important work that you're doing. And we wish you all the best in managing this as you go forward. So everyone, please join me in thanking Nicole one more time. And again, thank you, and we'll see you all soon.
Thank you all so much, and happy to be a resource however I can be for folks as you move forward in your careers. So Tim, thanks for thinking of me. Angela, folks, thanks for having me.
Yeah, thank you so much. Bye, everyone.
Bye.